Good afternoon, everyone. Welcome, 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 welcome. We welcome you to this Maternal and Infant Health Project ECHO Maternal Infant Health Series, Education Series. We're happy to see you all joining from your respective communities. Wayside is excited about having Dr. Rachel Hardeman speak to us today. Our agenda for today is, again, my name is Nicole Fernandez. I am the project manager for the Maternal and Infant Health Education Series with Wayside Recovery Center. We will just hear a little bit about Wayside Recovery Center. I will give a brief introduction of our speaker. We will hear from Dr. Rachel Hardeman, and there will be a brief time, about maybe 10 minutes for question and answers. You can place your answers in the Q&A section. We will do our best to get to all questions. This session is being recorded and will be posted for a brief period of time and shared with you via YouTube. And then we will have our closing and information about our upcoming series. Links will be placed in the chat. So I would like to welcome you today. We will have a great time today with Dr. Rachel Hardeman and learn from her. A little bit about Wayside Recovery Center. Wayside Recovery Center is a gender-specific based facility. Understanding the needs of women is critical to optimizing prevention and care for women with substance use disorder. Wayside has been in existence for over 60 years. We specialize in empowering women and breaking generational cycles of substance abuse. Wayside also, if you do not know, we are a certified community behavioral health clinic. Wayside now provides services to address the whole health that are more affordable and more accessible. Wayside Recovery Center is hosting this Project ECHO series, which ECHO stands for Extension Community Healthcare Outcomes. It is a series in partnership with the Minnesota Department of Human Services, focusing on reducing maternal and infant health disparities. This series will run until March of 2023. I would like to introduce our speaker for today. Dr. Rachel Hardeman is a tenured associate professor in the Division of Health Policy and Management at the University of Minnesota School of Public Health, the Blue Cross Endowed Professor in Health and Racial Equity, and the founding director of the Center for Anti-Racism Research for Health Equity. A reproductive health equity researcher, she applies the tools of population health science and health services research to elucidate a critical and complex determinant of health inequity and racism. Dr. Hardeman leverages the framework of critical race theory and reproductive justice to inform her equity-centered work, which aims to build the empirical evidence of racism's impact on health, particularly for Black birthing people and their babies. Dr. Hardeman earned an undergraduate degree in chemistry and Spanish from Xavier University in Louisiana, and an MPH in Public Health Administration and Policy, and a PhD in Health Services Research and Policy from the University of Minnesota School of Public Health. Without further ado, I'd like to introduce you to our speaker, Dr. Rachel Hardeman.
Thank you so much, Nicole, for the warm introduction. And I just want to thank Wayside and Representative Richardson for the invitation to join you all today. I'm really excited to be here and to share some of the research that I, along with my colleagues in the Center for Anti-Racism Research for Health Equity, are doing related to the intersections of Black motherhood, Black maternal health, and policing and police violence. So without further ado, I think I'll just jump right in, because I do want to make sure that we have enough time to have a question and answer session. So again, I'm thrilled to be here to share space with you today. And I want to start by centering us on what is most important, and that's the lives lost and the injustices faced by far too many Black mothers and fathers and families. The photo you see here is of my daughter. It was taken on May 25th of 2021 at George Floyd Square on the 1-year anniversary of his murder. The words you see next to it are an excerpt from an op-ed that I wrote for the Star Tribune on the 1-year anniversary of George Floyd's murder, where I reflect on what it's meant over the past years and where we're headed. And it was titled Hopeful Yet Afraid to Hope. And I think what you'll see through my presentation and the research I share with you today is exactly why I feel hopeful yet afraid to hope. So I'm going to read these words to really frame for us our time together and sort of help us to understand the connections that I would like you all to make today. And what of the mamas, those wanting to simply protect their babies in utero and in arms? They tell me they fear finding out they are having a boy. For to raise a Black son in America means to constantly be worried that the child will be seen as too threatening or too aggressive, like 12-year-old Tamir Rice killed by a Cleveland, Ohio police officer. Black mamas are holding their daughters closer because we know Black girls will be presumed to be older, less innocent, and less in need of protection than white girls as early as 5 years old. As Black parents, we know the risk our children may face when they leave our sides, and we hide our silent devastation when we prepare them for those risks. Risks that no amount of guidance may deter. We are afraid to hope. So I'm going to start with a little bit of background data before digging into sort of the main topic of the presentation today. And I won't spend too much time here because I'm sure most of you are quite familiar with some of the statistics that we're facing as a country as well as a state. So we know that each year in the United States, between 700 and 900 women or birthing people die of pregnancy-related causes, making the United States the only developed country in the world that has the highest and an increasing maternal mortality rate. Maternal mortality has nearly doubled in the United States over the past couple of decades, while it's literally declined everywhere else across the globe. And certainly maternal mortality is a clinical, a public health, and a social crisis. And we know that the risk for maternal mortality is unevenly distributed, with some populations bearing substantially greater risk. So among the groups at highest risk for maternal death are Black and Indigenous birthing people, both across the country as well as here in Minnesota. So we know that Black birthing people are at least 4 times more likely to die of a pregnancy-related cause in comparison to their white counterparts, and that's regardless of education levels and socioeconomic status. We also have grappled as a nation with our infant mortality rates. So certainly preserving the lives of newborns has been a long-standing issue in public health and social policy and in humanitarian endeavors. And to be clear, a high infant mortality rate is generally indicative of unmet human health needs in sanitation, medical care, nutrition, education. So, as I teach my students in the School of Public Health, infant mortality is a critical marker of health and well-being and how we are caring for the most vulnerable in our society. So that makes it even more concerning, in my opinion, that the United States, the wealthiest nation in the world, grapples with incredibly high infant mortality rates. And unlike maternal mortality rates, where we've just sort of recently started to pay closer attention to those data, we've been collecting data on infant mortality for decades, for centuries. So historical demographers estimated in 1850 that enslaved infants died at a rate that was 1.6 times that of white infants. In 2016, CDC data shows us that Black infants have an infant mortality rate that's 2.3 times higher than white infants. So over time, while we have seen the infant mortality rate slowly decline overall across the United States, the gap between Black and white infants in the US has either gotten worse or it's stayed about the same. And again, Minnesota, we're not immune to these startling and concerning statistics. So my work and the work of my research center is really centered on getting at the root of the problem, with the notion that pulling up the root is where we can create that sustaining and endurable change. And that also means we have to understand the historical context, because while our findings certainly reflect current reality, the data I just shared with you reflects our current reality, much of what we're grappling with has a historical context that's incredibly important to understand in order to move forward. So I always say that we can't have a conversation about racial inequities in health and well-being, or in maternal and infant health in particular, and be ahistorical. It's just not possible. So what you see on this slide is the fact that in 1619, a group of 20 Africans were sold into bondage in Jamestown, Virginia. And the current infant mortality and maternal mortality data that I just shared with you is inextricably linked to the year 1619 and every year in between. And what these timelines remind us of is just how deeply ingrained racism and white supremacy is in our country and our nation, and how it's taken on different shapes and forms, right, over decades, over centuries. What I think is important to draw your attention to on the bottom timeline is the fact that Black enslavement comprised 60% of our country's history, and Jim Crow, so state and local laws that enforced racial segregation, made up 20% of our country's history. So 80% of our country's history has been steeped in either slavery or Jim Crow laws. And then what we've seen is that, racism and white supremacy show up, take different shapes and forms, whether it's in mass incarceration, the war on drugs, police violence, as I'm going to talk about today, and other social issues that plague our society. So in my talk today, I am making an important link between the intersections of racism and police violence and maternal and infant health outcomes. And so to do that, we have to also understand the history of policing and how that's taken on different shapes and forms over the years. Policing and police violence, police brutality clearly is not a new issue. So dating back to the 1600s, the United States, which was then a British colony, used a watchman system, where citizens of towns and cities would patrol their communities to prevent things like burglaries, arson, and to maintain order. And then as the enslaved population increased in the United States, slave patrols were formed in places like South Carolina, and then expanded to a lot of the other sort of southern states that were using slavery. So slave patrols lay at the roots of the nation's law enforcement planning, right? Helping to launch centuries of violent and racist behavior towards Black people, as well as a tradition of protests and uprisings against police brutality. So slave patrols continued until the end of the Civil War and the passage of the 13th Amendment. And then following the Civil War, during Reconstruction, slave patrols were replaced by more militia-style groups who were empowered to control and to deny access to equal rights for freed enslaved people. So they relentlessly and systematically enforced Black codes. So they were strict local and state laws that really regulated and restricted access to things like labor, wages, voting rights, sort of all of the normal, rights of our society, general freedoms that were due to formerly enslaved people, but militia-style groups who were formed from those slave patrols, their goal really was to prohibit that from happening. And then in 1868, with the ratification of the 14th Amendment of the US Constitution, it technically granted equal protections to Black people, so essentially abolishing those Black codes. But then that's when we saw the Jim Crow laws that I previously mentioned take hold and legalize, racial segregation sort of swiftly fell into place. And so by the 1900s, local municipalities began to establish police departments to enforce local laws, both in the East and the Midwest, including Jim Crow laws. So the local municipalities really leaned on police to enforce and exert excessive brutality and control over Black people who chose to violate the Jim Crow laws. And that continued, we saw that continue through the end of the 1960s, really. So the point is that, the reasons for establishing policing were different both regionally and across time. But one thing that has remained the same and consistent through all, from slave patrols to our modern day policing system, is that it was based on both othering people and really ensuring that control was exerted over certain populations, essentially non-white populations. So police violence and racial inequities in maternal and infant health, I would argue, are concurrent and compounding public health crises that have to be examined. The intersections of the two have to be examined in order to work towards our overarching goal of reproductive health equity. So I'm going to spend our time together really kind of digging into how I see these two things being so deeply connected. But first, I want to make sure we're on the same page as far as the definitions go. So when I talk about police violence and policing and surveillance, I'm talking about a form of structural racism. And structural racism normalizes and legitimizes a lot of different sort of dynamics in our society, from historical, cultural, institutional, and interpersonal, with the ultimate outcome of routinely advantaging white people while producing cumulative and chronic disadvantage for Black people and other people of color. So we're talking about a system of hierarchy, of inequity that's replicated in a variety of different ways, as you see on the slide, from voting rights, FHA loans, residential segregation. We see it in healthcare and our criminal injustice system and many other ways. It's also fueled through implicit bias, which I think is important to comment on, but also I want to be careful to not suggest that it is sort of the answer, right? Because I think we have often relied on implicit bias or unconscious bias as sort of the path forward in fixing some of the inequities we see. So I think it's important to note that implicit bias is an important part of structural racism, but it's not going to lead us towards the structural change and the systemic change that we need in order to ensure that moms and babies have the best outcomes possible. One of the things I do think we need to focus on as we do the work of reproductive health equity is reproductive justice. So reproductive justice is often solely framed around birth control and abortion access, which is a timely discussion certainly today as the US Supreme Court considers the case in Mississippi. But also, I would argue that reproductive justice and reproductive rights is also deeply tied to ending police violence and thinking about the damage it causes to families. So sitting at the intersection of reproductive justice and police violence are mothers, for instance, who play a preeminent role in the movement against police violence, because motherhood never ends, right? It never ends, even with the loss of a child. And that connection to between reproductive justice and ending policing can be seen in how police violence both tears apart existing families and steals the children that Black parents already have. So reproductive justice, which is a framework that was put forth by a group of Black women who felt like the reproductive rights movement was not fully reflective of certainly for Black women, but also of the reality and lived experience of people sort of who had intersecting identities. And so from that, the reproductive justice movement was born, and it refers to the human right to maintain personal bodily autonomy, to have children, to not have children, and to parent the children that we have in safe and sustainable communities. So again, the reproductive justice movement, embodies women of color's recognition that it's not only important to fight for the right to have a child or to not have a child, but it's just as important to advocate for the right to parent children in communities that are free from police violence, are free from surveillance, where children feel safe, feel loved, and don't feel at risk. It's certainly haunting and painful as I reflect and have reflected for over a year now on some of George Floyd's final words, which were a cry for his mom, right? A cry that was so deep, as you see on this slide, it summoned all mothers when he called for his mom. it's an unenviable task to be a mother to a Black child in America. And the Mothers Movement is a group of parents, some of the most high profile Black victims of police violence in the United States, each who found themselves raising and then losing a child in a system that was stacked against them. And so I just think it's important to bring some of those names and those faces into our virtual space as we think about these issues and the intersections of these issues. So you see on this slide, Sandra Bland's mother, Trayvon Martin's mother, Eric Gardner's mother, and Sean Bell's mother, all people who were killed by police. So the intersection between reproductive justice and police violence, again, sort of extends beyond whether or not we want to have children, and really forces us to think about how do we create the social factors and the social determinants that make it possible to raise children in the way that they deserve, and ensure that that violence doesn't rob them of opportunities to care for children or deny them the possibility of creating a family by taking the lives of parents and parents to be. I often think of Breonna Taylor, who had the hopes of becoming a mother before she was killed by a police officer in Kentucky. In Christmas of 2019, less than 3 months before her death, she had tweeted, quote, "I hope next Christmas I have a kid so I can be super, super excited today like y'all." So part of the premise of my research that I'm going to share with you today is that, police violence and racism in general can be insidious threats to a Black woman's reproductive health, damaging well-being and possibly even the DNA of her children. And I'll share some of the research that we've done that really points to this direction, and thinking about how vicarious trauma through police violence can impact birth outcomes, for instance, and it certainly impacts what we see in our research, how Black birthing people or Black women mother their children. So my work, again, is based on both the premise that reproductive justice and the idea of becoming a mother and not becoming a mother, or parenting as a Black mother, are critically important to how we understand racial equities and maternal and infant health outcomes. And so this work is done in conjunction with colleagues across the country. And I'll talk a little bit more about sort of both what we're working on now, but also what we found in our early work, which really outlines the pathways that you see here on the screen around police violence as this manifestation of structural racism that's impacting psychosocial stress during pregnancy and during the childbirth period, and even postpartum as well. We haven't looked specifically at the postpartum period yet, but it's certainly an important piece of this puzzle. And ultimately impacting the maternal and infant health inequities that I started out this talk describing. So the premise of our work is that beyond the tragic deaths that occur due to police brutality, the effects of the violence permeate the very conditions of existence in communities that are already marginalized, that are already vulnerable. So over surveillance and marginalized and in vulnerable communities, coupled with the looming fear of death at the hands of police, can affect every aspect of life within Black and Brown communities. And we have to understand these pathways. We have to understand the associations and the links here to reproductive health in order to do the work of creating policy, right, and creating legislation and creating systems that disrupt that pathway. So in the first study we conducted, we were really interested in, before even thinking about police brutality or police violence, just simply thinking about police contact, right? So surveillance, living in communities where police presence is disproportionately high. So our questions were, does excess police contact increase the risk of preterm birth? And if so, does the effect vary by the racial group of the pregnant person or the birthing person? Also, we asked, is it the police contact per se, or the racialized pattern of police contact that contributes to racial inequities in preterm birth? So if it's police contact, then it will see a positive association observed only among Black birthing people. If it's racialized police contact, so a positive association would be observed among all of the racial groups in our study, but the exposure pattern of police contact would be racialized, meaning that we would likely see more police contact in neighborhoods that are defined as predominantly Black. So I won't spend a ton of time on our methods. I'll just say that we use birth records from the Fairview Health System from 2016 to do these analyses. And we restricted our sample to white birthing people, US born Black birthing people, and Black immigrant birthing people. 96% of the Black immigrant sample were born in sub-Saharan countries. And the outcomes we looked at were preterm birth, or in this case was preterm birth. So this gives you sort of an idea of our sample characteristics, but for timing, I won't spend a lot of time or any time really sort of walking through this, but I'm happy to come back to it if people are interested. I think one of the things most folks are interested in is how we operationalize or how we thought about police contact. So we thought about police contact as a place-based exposure and measured it at the census tract level. So we use the police incident data from the city of Minneapolis police incident report. So it's public data that the Minneapolis Police Department puts out. They make it available to whoever wants it. And that's how we came up with this police contact measure. So the figure that you see here, sorry, it's a little bit blurry. I didn't realize that when I put it in there, but it shows the proportional distribution of offense type between 2012 and 2016. So it's everything from theft, burglary, robbery, assault, murder and homicide, which is actually pretty low. For between 2012 and 2016. So all reasons that police contact or police presence in a census tract or in a neighborhood would happen or need to occur. This slide has a lot of words on it that tell you through all of the different types of analyses that we ran and conducted for the study. The paper is actually coming out in JAMA, I think next week. And so if anyone is interested in more of the details of the analysis, I'm happy to send it along then. But again, for the sort of purposes of this presentation, I won't dig into it other than to say that our results revealed that high police contact increases the risk of preterm birth by 84%. And then when we added the interaction term to our sort of larger models, we didn't find any statistical significance. But again, the point to walk away from is that high police contact increased the risk of preterm birth, so birth before 37 weeks gestation. And that's after controlling for a variety of covariates and things that we also know would matter, right, for impacting preterm birth. And then in our secondary analysis, we tested for what we call spatial autocorrelation between the proportion of Black residents in all Minneapolis census tracts and the cumulative police incidence accounts. And so we were really interested in sort of understanding where police contact was sort of most clustered and most happening and what neighborhoods that was in Minneapolis. And this gives you a sense of what that looks like. I tried to sort of match it with a map that actually gives you a sense of the Minneapolis neighborhoods, or else I feel like the findings are not quite as useful as they could be. So we found a positive measure of spatial autocorrelation between the proportion of the population that identified as Black and the number of police incidents, which really just means that in neighborhoods that were predominantly Black, we found it was more likely that there was higher levels of police contact there. So the map shows sort of 5 types of neighborhoods, in Minneapolis. Types meaning we created these types based on our data, our analyses. So red indicates the clusters of census tract with a high proportion of Black residents that also have high police incidents. So these red places here. So those are neighborhoods like Jordan, Hawthorne, near North, and then in the South, it's neighborhoods like Phillips, Midtown, Whittier, Central. And then dark blue are the neighborhoods with a low proportion of Black residents and also low police contact or police incidents. And that's these right here. And then the pink, there's just this one pink square here. I'm pretty sure that's sort of the Regina Kingfield neighborhood. And then the purple areas, which are sort of Seward, Longfellow, Bancroft, and then parts of Lynn Lake over here, our neighborhoods are census tracts that had a high proportion of Black residents and lower police incidents. And also those with low proportion of Black residents with high incidents. So the purple is more of the low proportion of Black residents with a little bit higher police incidents. And then the gray there was no significant sort of autocorrelation in the gray areas of the city. So what that tells us is that first and foremost, our findings revealed that exposure to high police contact increased the risk of preterm birth. Interestingly, it increases the risk of preterm birth for both Black and white birthing people. We see that high police contact is associated with an increased, again, sort of with this increased risk overall. We kind of went into this work thinking we would see a difference for Black versus white, but it seems like where you live matters and the amount of police contact or surveillance in that neighborhood matters more. We also, confirm, and this is not surprising based on the conversations that we in the city of Minneapolis have had for many years, and are certainly having now around sort of policing and police surveillance, that Black neighborhoods have more police contact. And the bottom line is that we have to really think about how, this pathway and this mechanism of racialized police contact contributing to inequities in preterm birth. Of course, we have a series of next steps and things that we'll do once we have this particular publication out to continue this work. I'm happy to chat more about that, or if anyone has any thoughts or ideas or things you want us to think about, feel free to jump in during the Q&A. So now we have this snapshot of what's potentially happening with respect to police contact or police surveillance and babies in utero, those preterm births. I think, a reproductive justice framework also compels us to consider what feelings persist for Black mothers, so people who already have that baby in arms, in the aftermath of the continual loss of Black lives at the hands of police. And we started this work through a mixed methods study many years ago, actually, several years ago, just after Philando Castile was murdered in Falcon Heights by a police officer. And we came to this work and to this question in a variety of different ways and through a variety of different lived experiences amongst our research team, but also because in another research project not related to police violence, but a project where we were having discussions with Black families and Black pregnant people, we kept hearing this sort of resounding theme from Black mothers or Black birthing people that they didn't want to find out the sex, the gender of the baby that they were carrying during their 20-week anatomy scan. And as we were having more discussions with those families, what came to light was that, in the aftermath of Philando Castile's murder, the stress of knowing that a woman was carrying a boy was just too much to bear for some people. And so that's really what led us to dig into this question and piece together, it's interesting, we pieced together a lot of little bits of funding to ask these questions and to do this work. Certainly the landscape's changed and now there's a lot more support for these questions, but 4 or 5 years ago, that wasn't the case. So we put together a mixed methods study where we conducted a survey with almost 300 Black women of reproductive age in the Twin Cities. We also conducted some qualitative work, so focus groups and interviews with about 50 Black women of reproductive age in the Twin Cities. And really our goal here was to bring to light and the lived experience and the stories of Black mothers. We started out with just North Minneapolis, but expanded beyond that as time went on with this work. And one of the other, I think, important points that are parts of this study was that we worked in partnership with some wonderful community organizations to do this work and to really build some great research relationships there. So we're still in the process of describing a lot of our findings and sharing them and doing that together with our partners. And so I only share a little bit of what we are learning 4 or 5 years later. That's another thing we learned, that the the speed of this type of work can only go at the speed of the partners that you're working with and what the community needs. And so we had a lot of starts and stops as different traumatic events happened in our communities, and we would have to pause and deal with the aftermath of those events before moving forward. So we actually didn't finish our survey completion until maybe about 3 or 4 weeks before George Floyd's murder. So it was, it's been a long haul with this project, and a labor of love, certainly. But, you know, on a basic level, some of the things we see is that from the wonderful women who chose to respond to our survey, that there certainly is a fear of policing, of police officers in their communities, and a fear of police violence happening in the communities in which they live in across the Twin Cities. We asked, to what extent has living in a community with police violence impacted your decision to have or not have a baby? And 56% say it probably or definitely had an impact on their decision to have a baby. What we don't know is sort of the direction, right? Like the directionality of that. I think it's an important question to think about, both as we see different states being, women in different states being stripped of their rights to make that decision, every day. Certainly the Texas Senate bill that recently passed is a concern there. But also, I think that there's a lot to learn about choosing to give birth during times like these as an act of liberation and of resilience too. And so I'm really looking forward to digging more into those questions. And also, almost 75% reported that living in communities where there's been police violence has impacted the ways that they parent their children. And we did dig into qualitatively into some of those themes around parenting and motherhood. And we heard a lot of stories around hypervigilance and this need as a Black mother to always be watching their children and not sort of letting them stray too far from home for fear that something would happen, or fear that they wouldn't be protected if they were in a situation where that was needed. And that sort of ties to the protective parenting theme, and also this need and this desire to prepare kids for how to react and interact with police. One of the moms said, I have to prepare, I said to my kids, I have to prepare you guys so that you don't get killed because you're Black. The first thing I think of is protecting my kids, protecting my heart. It's, I always have to remind them to remember the rules, to remind them this is how we drive, this is what we do. Police are not here to save us anymore. They're here to take our lives away, is how she ended her statement. We also had a lot of questions, and this was our discussion around police reform. This was prior to, I think, well before, years before the discussions around public safety and policing surfaced in our communities here in Minneapolis. But certainly even, 3 years ago, as we were having these conversations, this reimagining of public safety was happening. And I think it speaks to how powerful the ideas are in our communities that we need to tap into as we chart our path forward. And so I'm going to skip to the next slide just to say that now I'm excited for the work we're currently doing in my research center. We were just funded, well, I guess about 4 or 5 months ago, we were funded by the National Institutes of Health to dig into these intersections even further of police violence and reproductive health. So we are looking both locally and nationally to understand how patterns of police violence in communities across the country impact things like preterm birth, low birth weight, infant mortality. So we just launched a 5-year study to do that. And we'll also be doing some qualitative work to have conversations with people both here and in Louisiana, where our other research partners are, to really talk about what's going on and what that lived experience is. And certainly thinking about how the intersections of the COVID-19 pandemic and its disproportionate impact on Black communities, as well as George Floyd's murder, have impacted reproductive health and well-being, reproductive decision-making for Black birthing people. So I'd love to come back and share those findings as we move that work along. How am I on time? Sorry, I kind of lost track of time a little bit.
We are at 12:42, so I would
Okay.
say another 8 minutes.
Great, I can do it. Perfect. So, I mean, I think I shared with you a lot of concerning data and information, and certainly things that keep me up at night. And I think I want to close with a few slides around, because the next question that people often ask me is sort of, what do we do? What's next? And while there's not, obviously, if there was some perfect answer, we would have fixed these issues already, and that's not the case. And I think it requires a lot of work and a lot of different angles, and by all of us, to really pull up the root and begin to plant, new seeds that are anti-racist, that are, intentionally working towards creating reproductive health equity. So I'm briefly going to share some of my thoughts that I've put in writing and published over the past few years that I think are the steps we need to be taking to get towards that, to achieve that goal. So the first step is, how do we create or transform into our anti-racist best selves, right? So I wrote this piece with my colleagues in 2016, just after Philando Castile was shot and killed by a Falcon Heights police officer. And our goal with this piece was really to put forth a call to action to our colleagues. So our research colleagues, our clinical colleagues, to say, we all have a role to play in dismantling structural racism and in supporting Black lives. And so some of this I walked you through today, right? So I talked about our first part of the call to action, which is to learn about, understand, and accept the United States racist roots. We can't approach this work from an ahistorical standpoint. We have to understand how racism has shaped our narrative about disparities. And then we have to be able to define and name racism and not be afraid to say what's happening, and embrace that, because if we don't, we can't change it. It means we have to recognize racism, not just race. So, I think we often will talk about differences or disparities by race without really understanding or talking about the mechanisms behind it and why those differences exist due to the root cause, structural racism. And then, the fifth part of our call to action is that we have to center at the margins. And, I encourage you all to think about what that looks like across the spaces that you're in and the work that you do. And how are you ensuring that the people who are closest to the pain of maternal and infant inequities by race are really leading the work and are the ones that are generating the solutions and the ideas. It also means that we have to think about the hierarchies and the power structures within the institutions we work in. And that's not to say that everyone has the power right now to transform the institution that you're in, but by both critically reflecting on your own role and that of those around you, it's an opportunity to really, I think, have some important conversations that can slowly sort of shift some of the institutional, or make some of those institutional changes that are needed. I won't spend any time, just for the sake of time, on this slide. If anyone in the audience is a researcher and wants to talk more about anti-racist research, it is the sort of foundation of the Center for Anti-Racism Research for Health Equity and the center of the work that I do. And so I will refer you to this paper that I wrote with one of my incredible doctoral students, J-Mag Carbia, where we outline, I call it a love letter to the field, where we really both critique where we've been, but also outline the path forward towards what we call emancipation from the dominant frame of white supremacy in research. So just after George Floyd's murder, in the midst of a global pandemic, my colleagues and I published this paper in response to, as a follow-up really to the 2016 piece that I first shared with you, but really focusing on what do anti-racist healthcare systems look like? What is the next what's the next, what's the next step? And we really highlight the intersections of COVID-19 and its disproportionate impact on Black communities and police violence, and offer opportunities for our health systems to transform and directions for us to consider, starting with a divestment from racial inequities. We state that racial health inequities are not signs of a system malfunction. They're actually a byproduct, right, of a healthcare system that's functioning as intended. And it's our job to divest in a way that moves us beyond that. And by doing so, we have to desegregate the healthcare workforce. We have to think about how we can make mastering the health effects of structural racism a professional, in the paper we say medical competency, but really it should be a competency for everyone from, social workers, anyone who is facing caring for people and communities that are deeply impacted by structural racism. We also have to mandate and measure equitable outcomes. So just in the same way that our healthcare systems are accountable for a variety of different accreditations and accreditation bodies, equity and anti-racism should be a part of that accreditation or regulation process. And then ultimately, it's the role of our systems to protect and serve. And that means both protecting and advocating for patients, including victims of state-sanctioned violence. It means thinking about the research I've done with Dr. Syria Long, where we found that people who have experienced police violence or police brutality in their lives are less likely to utilize healthcare and have a greater level of unmet medical need, because these systems, our systems, whether it's policing or healthcare or education, they don't operate in silos. They're all intersected and having an impact on one another. And it's our job to understand that and and play a role in protecting folks who are harmed in one system as they enter or choose not to enter another system. And a lot of that work, requires, policy initiatives, right? So I started out by talking about our role as individual people, but we also have a role. So we have that role to play as individual people, thinking about these issues and thinking about where we occupy space and how those conversations can look. But we also have to be thinking about how our role in influencing policy. So we wrote this, my colleagues and I wrote this paper just as the Biden-Harris administration was beginning to really frame the role of dismantling structural racism through policy. And again, for the sake of time, I won't go into sort of all of the details of what we put forth here. I'm happy to send a link for folks who want to read it. But I think the role of state, both state and federal policy, in creating opportunities for the social determinants of, prioritizing policy that supports and impacts the social determinants of health is incredibly important. So with that, I will close out. I really appreciate your time today, and I'm so grateful for all of you for joining us. I also have to give a shout out to my incredible team at the Center for Anti-Racism Research for Health Equity. We are all working incredibly hard in all of these spaces to improve health and well-being for Black birthing people and Black and Brown communities across our country. So thank you.
Thank you so much, Dr. Hardeman. It's really powerful to see information together. I love timelines, to be able to understand where have we been, where are we going, and what has impacted our health disparities, what's impacted our care and who we are in this country around public health. Thank you so very much. I'm going to turn it over to Zora Darkot, who will handle our question and answer sessions. Please post your questions in the Q&A and Zora will moderate. Thank you so much.
Thank you. Thank you, Dr. Hardeman, as well. You're doing amazing work, and I think this was a really powerful presentation. So it looks like we do have one question in the chat right now. It says, do you think implementing mental health services and workers on the police dispatch team will be helpful in mitigating the concerns with the approach to policing and police violence in BIPOC communities?
That's a great question. I think that, so I struggle with this in all the work that I do, right? Because I think what we see and what the data show and what the reality shows for Black communities and Black people is that the current system, as I said before, it was never designed to work for us. And so, I think the same can be said for policing, right? And that it was never designed to to keep people in their care, right? It was designed for the exact opposite. And so part of me feels like, I think there's a lot of noble efforts to do things like implementing mental health services and workers on police dispatch teams. And I think it's a worthy initiative, but I think it's not going to solve the whole problem, because until we actually dismantle the system that has its roots in actually controlling and harming certain people, I mean, there's only so much we can do, right, to sort of put the Band-Aids on it. And I think we see the same as we think about our healthcare delivery system, which was actually never created to ensure that Black moms thrived, right? Black women historically their bodies were used for research in our healthcare systems. There's a long history of segregated care, of Black people dying because white physicians, there wasn't a Black physician to care for them, and white physicians refused. And so, we're simultaneously working to sort of shift things within the inside of a system that actually was not designed to care for certain populations, while also trying to reimagine, right, the whole thing. And so I kind of try to hold both. That's a long-winded way of saying sort of, I feel like I have to hold both of those. So yes, I think it's a useful approach and an important approach, but also we have to be thinking sort of bigger and I think more radically than that.
Thank you. There's another question in here that says, we are seeing what research is showing. Is there anything we can do as a community or professionals to be proactive and not reactive?
That's very general. I don't know if there's if that's it with respect, or what that's sort of with respect to. I mean, I think, certainly as I, ended the talk and saying both the role of critically evaluating or reflecting on your own positionality, who you are, how you show up, how you get to, like, how much of a voice you get to have or not, right, where your privilege lies, I think is incredibly important. And then taking that reflection to have a creative sphere of influence within your own sort of particular space. But also, I think we are conditioned to think that we don't have a role to play in the policy sphere, and we do. And I think, we're watching it today. I mean, I'm watching it today as the US Supreme Court hearing is happening, and the voices around pushing back around women's rights and really, getting sort of messaging into the forefront or in that space. I think we each have a role to play in that as well. And that, I think, is proactive, right? And thinking about what legislators you should be writing or having conversations with. And I mean, often we're always thinking about that in my research center too. And how do we leverage the work we're doing and get it in front of policymakers to have those important conversations?
Yes, let me see. Again, if you guys have any questions or comments, this is your opportunity to ask in the chat. I am seeing some just comments that this was very informative.
And Zora, Sean is saying, he posted in the chat, it's okay, we're monitoring both. If you put it in the chat, we'll grab it as well. Sean is asking, he's from Chicago, I'm a white man, age 59, how may I help?
So obviously I don't know you, Sean, but I think that a lot of what I just said sort of, is the starting point for that. And, one of the things that, I mentioned is centering at the margins, right? Really thinking about whose voice gets to be heard, who's at the table, who's not at the table. And then, as a white person, right, and particularly as a white man, there's an opportunity to step back and say, like, it isn't my voice that should be heard, but how can I facilitate other voices being heard? I think we're not conditioned to do that very well, just as human beings. And, I think I look at organizations like the Black Mommas Matter Alliance and the incredible ways in which they have, as an organization over the past year or 5 years, really lifted up and centered the voices of Black birthing people in this discussion around Black maternal mortality, and framed and sort of created a space to sort of frame the issues around those, again, who are closest to the pain of the issue. And so I think one of the things that's incredibly important for, I don't like the word allies, but for lack of a better word right now, I'll use that, to do is to both, is to create that space and hold that space, to allow for the folks who are typically at the margins to step into the center.
Looks like we have one more question, and this may be the last, looking at the time. It says healthcare, education, and delivery are based on a disease model, not seeing the whole person in most, if not all, contexts. The reproductive justice model is holistic, so how could we expand that perspective to all healthcare delivery, or where should we start? And they just mentioned that they know it's a pretty big question. But.
Yeah. Hi, Siri. First of all, thanks for joining us. Yeah, that is a big question. And I completely agree. I think that the reproductive justice framework is not just about reproductive health outcomes, right? It is a framework that that I see has the possibility and the potential to be used all across healthcare delivery and how we approach the work, and not even just healthcare delivery. It could be social services, as well, because it starts by lifting up, by honoring and creating space for the lived experience. My cynical side says we need a different healthcare system to be able to do that well, right? We actually don't have a system that creates time. I mean, 10, 15-minute visits don't allow you to build a relationship, to hear someone's life and understand sort of what they, how that's connected sort of to their current medical needs. So we don't have a system that is conducive to a reproductive justice approach right now. But I think certainly by understanding and reading both what reproductive justice is, as well as why it was created, right? I think the genesis of reproductive justice and why the group of Black women that created it did so, I think is an incredibly important way of thinking about how to start those discussions within our healthcare systems.
There is one final question in the chat, Zora, and that will be our final question for today. Thank you. Do you want me to read it?
Had to find it. So it says, and now, why don't you go ahead and read that one?
Okay, it says, is there research on birthing outcomes when white women birth Black and brown babies? Are the outcomes for mother and then also the child different than if it is a Black and brown woman birthing a Black and brown child?
That's a really interesting question. I don't know, actually. But it's kind of related to some of the research and the discussion that I'll be having next week. So maybe we can dig into it more then.
Wonderful, wonderful. Well, I just want to thank you, Dr. Hardeman. And I do want to acknowledge Camila mentioned, this is hard, and it's a hard topic to listen and learn. So we do want to hold space for those feelings, those emotions, and I hope that you give yourself time to process this information and really think about carefully, what can you do in your communities? What can you do in your spaces? And again, the most important question is who's not at the table? And hopefully you'll share that this video will be posted in a couple of days and that you'll continue to follow Dr. Hardeman's incredible research. I know that the U of N puts out many publications and information to keep us updated on the great work that they're doing. So thank you, Dr. Hardeman, and thank you again to our sponsors, Minnesota Department of Human Services, for bringing this valuable echo to us. And please remember to join us on the 8th. Dr. Hardeman has a follow-up. Yes, there is more. Black Babies Matter on December 8th at 12 o'clock. Thank you so much, and everyone have a wonderful afternoon and be well.
Thanks, everyone.